Welcome everyone to Mini Med School. This program is organized and put on by the UNC MD PhD program. So all of the people who are helping today and who organize each of these talks are actually students in our program. My name is Paige. I'm a fifth year in the program and am one of the co-directors. Matthew is one of our other co-directors back here who runs all our AV stuff as well. Nana and Sergey help to check you in. Monica's also there in the back and helping out. But with that, I will happily begin to introduce our student speaker for tonight. I'm happy to introduce Hannah Phelps, who is a first year in our program, just getting started. She did her undergraduate degree at Florida Atlantic University in biology, and then she continued on to do a master's in neuroscience at the University of Florida. She is generally interested in studying neurodegeneration as well as substance use disorders for her research in the future. And with that, I will hand it off.
Is the mic good? Okay, perfect. Hi, everybody. As Paige mentioned, I'm Hannah. I'm a first year in the program, and I'm going to be giving a warm-up talk for our talk coming up from Dr. Justin Coley, and he's going to be talking about adolescent mental health, but I'm going to give a little introduction on what mental health is and why it matters to talk about. So why does mental health matter? First off, it's universal. Everyone has it. Just like our bodily or physical health, everyone has mental health. It affects every aspect of life, including how we think, feel, and act, how we cope with stress, how we interact with others, make decisions, and contribute to our communities. So not only does it impact everything that we do, it also impacts people around us. So it's very important to talk about and to learn about our mental health and the mental health of everyone around us. So when you've heard about mental health in the past, it may have been in a negative connotation. So what is the difference between mental health and a mental illness? Mental health is the state of your mind, feelings, and emotions. Good mental health allows us to feel, think, and act in ways that help us to enjoy life and to cope with its challenges. Mental health is always present and can be positive or negative, much like our physical health. So much like how you can have a generally good health and then fall sick with the flu or COVID or something more chronic, that can also happen with your mental health. So mental illness is a health condition that significantly affects a person's thinking, feeling, or behavior, and often causes distress and impacting their ability to function in daily life. And this chart is going to show us the difference between mental wellness, mental health, and mental illness. So on the left, we can see mental wellness, which refers to the positive side of mental health. So maintaining and striving for mental wellness is equal to working towards good mental health. In the middle, we have mental health, which is more of a neutral term that refers to the cognitive, behavioral, and emotional well-being. And mental health affects how we think, feel, and behave. And this includes how we handle stress, relate to others, and make choices. And mental illness is on the negative spectrum of mental health, referring to mental health disorders. So these are conditions that affect your mood, thinking, and behavior. And mental illnesses come in many forms, each with their own symptoms and treatment. So the impact of mental health is very important to talk about, and a struggle with mental health is common and does not mean someone is weak. And to talk about the numbers related to mental health, 1 in 5 US adults experience mental illness, 1 in 20 US adults will experience serious mental illness, and 17% of youth experience a mental health disorder. So it's important to talk about mental health and to learn about it because it impacts many people in this room and many people in the community. And to lean more towards that 17% of youth experiencing a mental health disorder, why is talking about mental health in adolescents specifically important? So to start by defining adolescence, it's the phase of life between childhood and adulthood from ages 10 to 19. And it's a unique stage of human development and an important time for laying the foundations of good health, both physical and mental. And adolescents experience rapid physical, cognitive, and psychosocial growth. This affects how they feel, think, make decisions, and interact with the world around them. And brain development is still ongoing during adolescence, which impacts emotional regulation and decision-making in adolescence. And specifically with adolescents in this current generation, there are increased social pressures, academic stress, and exposure to social media that can contribute to mental health challenges. And to think more about generally what we can do to help with mental health in adolescents, Dr. Coley is going to talk about how to identify different signs and behaviors in mental health, but to talk about some good action items for how to help with adolescents dealing with mental health disorders. So first of all, support your child, whether you are an adolescent or you know adolescents, a single supportive adult has been shown to significantly lower the risk of suicide and improve long-term mental health outcomes in adolescents. In addition, recognizing the signs and symptoms of mental illness, which you'll hopefully be able to do by the end of this talk, early recognition and intervention is incredibly important and can prevent potential catastrophe, prevent worsening symptoms, and improve long-term outcomes. In addition, it's important to encourage help-seeking behavior. It's important to normalize seeking mental health support, just like seeing a doctor for physical health. And then look into online or local resources. So provide trusted resources to your teen, such as different hotlines or therapy options. And we have a nice pamphlet that I've made that kind of outlines different mental health resources and LGBTQ resources, both online and in the area, that will pass out later today. And next, Dr. Coley is going to dive into more about how mental illness is diagnosed, important signs to look for in teens, potential treatment options, major challenges, and what we can do. But for now, I'll take any questions.
Okay, I think we're going to go ahead and get started. I give you just enough time to start talking again. It's my pleasure to introduce Dr. Coley today. He's third-year psychiatry resident here at UNC and will be starting his fellowship in child and adolescent psychiatry come July. Before coming here to UNC, he received his MD from the University of Virginia School of Medicine, where they completed research on community interventions for opioid use in rural Virginia. Since coming to UNC, Dr. Coley has continued research in community psychiatry with an emphasis on transitional age youth. With that, please welcome Dr. Coley.
Okay, let me see if I can attach this to myself, or I can just hold it as well. That's fine. I will be completely open and say public speaking does stress me out. That's why I became a psychiatrist. I'd rather talk to one person about what stresses them out instead of a bunch of people in a way that stresses me out. But I am a psychiatry resident at the University of North Carolina, and I'm starting my child and adolescent fellowship next year. I think Hannah did an excellent job explaining why we care about mental health, particularly in adolescence. Just so I can get a sense of the room, how many people have been to a mini med school talk before? Quite a lot of people. How many people are in college right now? A few people. How many people are younger than college? Quite a few people. How many people have adolescents of their own at home? A couple people. Okay. Well, I think we have a broad range here, but I think this talk is something that's important for everyone. So with that, we can get started. And I've already addressed this question to an extent. What is mental health? So health, I can read that out or you can read it yourself, but the sense is that it's really being well and being able to do what you want to do with your life. And health of the child is the most important thing because children are our future, and don't take it from me. That is from the World Health Organization. It's considered very important by some very important people. You can breeze through this real quick, but essentially, health is the quality of feeling good and doing good. It's doing what you want to do with your life, accomplishing what you want to achieve. And illness is what prevents you from being healthy. So that is why we care about promoting health and not just treating illness in medicine. Early mental health particularly is critical. So when we look at the research, I promise this is the only slide that has numbers on it. We know that 1 out of 5 teenagers has a mental illness, and about the same number has had thoughts of suicide at some point in their adolescence. As far as attempted suicide, that's about 3% among adolescents. Half of children with a mental illness do not receive any mental health treatment, and most of those that do, it's through a primary care physician and not through a mental health provider. Teens with depression are twice as likely to drop out of school, and half of all adult mental illness begins by age 14. So adolescence is an age when we have rapidly developing brain growth. Our brain grows the most in adolescence, just like our body does. And our brain keeps growing until we're 26. So everyone who said they're in college or younger, your brain is still developing. And because your brain is still growing, still developing, still forming those new connections, that age up until essentially the age a lot of people are when they finish med school. Your brain is still very malleable and able to be impacted by your experiences and by your health. And you take that health with you the rest of your life. So half of all people with mental illness had their mental illness when they were adolescents. Adults with mental illness have twice the rate of many different diseases, including the major killers, including heart disease, diabetes, stroke, and they're also a lot less likely to have good functioning in their adult life. So treating mental illness in young people is very important for making sure they have the life that they deserve to have. So this is a mini med school, and in my med school, and I understand the University of North Carolina as well, we have what we call learning objectives. So this is what we intend to learn from the presentation. We already covered what the difference between mental health and mental illness is, as well as why mental health in adolescence is critical for future health. We will go over some of the major categories of mental illness and mental health disorders that impact people and know how to identify the signs and symptoms of mental health. We'll challenge some common misconceptions about adolescent mental health that have become more common with social media like TikTok, and learn about reliable resources to learn more about the questions that can't be covered in the hour I have with y'all. And then also learn how to incorporate components of not just treating mental illness, but mental health into your own life, and know where to seek help for an adolescent or even yourself for mental health concerns. So I made this talk, geared as a talk about mental health from a very medical perspective, but I hope this is something everyone can take something from and use in their own life as well. So how do we diagnose mental illness to begin with? I'm pretty sure most of you have heard of something called the Diagnostic and Statistical Manual, or the DSM. The DSM has a strange name, Statistical Manual. The reason for that is historical. It was originally developed in the 50s or some long time ago like that. A couple people with gray hair laughing at me right now. But the first DSM came out quite a while ago, and it was initially meant to be a research document of how do we standardize people's brains into very discrete categories so we can do research on them, because we need things to be very standardized when you're doing research. The brain is not a standard thing. So a lot of the DSM is very rigid when we try and apply it to actual human people. But a key component of mental illness is dysfunction. So emotions are functional. They help us do everything we need to in our life. Even negative emotions, they tell us stay away from that thing, stop doing that thing, maybe do something better for yourself. Emotions are functional. So when you look at any diagnosis in the DSM, a key component is going to be this disorder causes some sort of distress or dysfunction for the person that is more than a normal emotion. Official diagnosis, as I said, is based on very strict criteria. You look at a very bulleted list of things, but real life experience is very variable and comorbidity is common. So when we talk about diagnoses, we often say, someone with depression, half of the people with depression will also have anxiety and vice versa. Are we overdiagnosing things? I think we're just making things too categorized. When we look at the DSM, I tend to tell people who are med students or learning that it's really not a bunch of discrete circles, but it's a lot of overlapping Venn diagrams. Mental health, people don't fall into one bucket or another. They usually fall between buckets. So finding the right diagnosis is sometimes an exercise in futility or doing it for the insurance company. But it's helpful to think of broad categories at the very least. So going on to some of those broad categories, the first one I want to talk about today is depression. If you look at a Psychology 101 textbook, you'll probably see a picture that looks somewhat like that. You see there's a nice sun in the background. She looks like she has her hair relatively well done. She looks like she's put together. It's just a bit sad. Depression more often looks like that. Depression is messy, and it is not a fun thing to be experiencing. I imagine most people have seen a teenager's room that looks like that. So not every room that looks like that means a teenager has depression. But when we talk about depression, again, thinking of the topic of dysfunctional, it is excessive sadness. We can ask the question, what does excessive mean? That is very subjective. Essentially, it's sadness that keeps us from dealing with the problem. Instead of feeling sad about something and handling it, we feel sad and we don't clean our room, we stay in the house all day. But the other component of depression, which can take the place of sadness, is anhedonia, or the lack of pleasure. Sometimes depression isn't sadness or feeling low, it's feeling numb, it's not being able to feel joy, it's not feeling excited by your friends or by the thought of a new job or, by that having a good cup of coffee in the morning. Things don't bring you joy anymore. So you don't have that motivation to pursue things in life anymore because you don't have that rewarding experience of joy from them. So it's not just sadness and it's not just feeling down, but it's really a much deeper experience than that for people. When I tend to assess people for mental health, one of the first questions I ask is, tell me what your day looks like. What do you do in the morning? What do you do in the afternoon? What do you do at night? Try and get a sense of what they're doing. When we talk about adolescents and we see depression, one of the things we tend to see is a change in what their mood is like or what they're doing during their life. They might have been interested in talking with their friends, or they might have had a good relationship with family, and now suddenly there's a change that we can't quite explain. They might be more irritable. They might not be as interested in things they used to enjoy. If they used to like school, they don't like school anymore. If they didn't like school, which is totally normal too, they don't like whatever they liked anymore. They're spending more time kind of by themselves, less time engaging with others. It's really this change in behavior that's important, not just the behavior itself, because change is normal in adolescence, and so is a lot of other things, but it's that kind of difference from baseline that is more than what you would expect from a normal grumpy teenager. It's something that's really impacting their ability to live their life. You can also see changes in appetite, changes in sleep, changes in kind of how they interact with people. Adolescents in particular, often, especially younger ones in the 10 to 12 age, middle school age, you might not see sadness itself, but you might see someone be more grumpy, more irritable. They can't quite explain yet what they're feeling, but they know they feel bad. So they tend to be, more impatient with people. And that might be confusing because it's not quite what you expect someone who's sad to look like. But the key takeaway is it's a change in what their mood and their behavior and their interests look like. That's more than just growing older, growing away from their parents. The next major category is anxiety, and there is a whole list of anxiety disorders in the DSM. Here are a lot of them in very scary red text. But the key thing about anxiety is that it's a fear of being afraid or avoidance. So if you think about depression as you don't get that rewarding experience anymore, you don't get that zing from doing something that brings you joy, you don't have an approach to, you have that lack of approach to things. In anxiety, it's more of an avoidance of things, you're running away from things. So anxiety is like sadness, is a normal emotion. It's a helpful emotion. It tells us, hey, this isn't quite right. Hey, you should be thinking about this. Hey, stop playing video games and study for your test. Anxiety disorders are that to the extreme, and people with anxiety disorders have more of that than usual. Instead of telling them, hey, stop playing video games and study for your test, the anxiety is so bad you can't study for your test, and that's where the dysfunction comes in. You often see that manifesting as avoiding what is causing someone anxiety or doing certain behaviors to avoid anxiety. So you think about OCD, people washing their hands all the time. Why do they do that? It's to get away from the anxiety that comes from an obsession about cleanliness. In panic attacks, people tend to avoid places that cause them panic. PTSD is on there. It's not truly an anxiety disorder. It's a trauma disorder, but it falls in a similar bucket. You avoid reminders of your past trauma. Social anxiety, you avoid social saturation. So one of the key things we see in adolescents with anxiety disorders is avoidance of things that they wouldn't have avoided before. They're not going to certain places, being around certain people, or they're not being able to tolerate doing things that would cause them stress that they normally would have been able to tolerate, like studying for a test, for example. Some associated symptoms you might see are impaired concentration if someone's worrying all the time or stressing out their brain. Sleep might change. You might see an increase in sleep as an avoidance behavior. You might see a decrease in sleep from the anxiety. There might be a lack of energy because of all the stress. And you might also see a lack of patience, again, because of that kind of constantly feeling burned out thing that you experience. As far as physical symptoms of anxiety, anxiety is coming from our fight or flight response. You can see a racing heart, short breath, muscle tension. And some people, that's all they notice. If you have less of a connection with your own emotions, you might say, I feel sick, my chest hurts, I have a headache. And that might be confused for a medical problem, but that could be anxiety in someone who has trouble expressing that they're feeling anxious. Another thing you sometimes see in anxiety is reassurance seeking. So again, that's an avoidance behavior in a way. You feel anxious, you can't manage, you constantly go to your parents or your friends and say, is this okay? Am I okay? That's also a manifestation that you might see in anxiety disorders. Another broad category of mental health that we think of in ADHD or adolescence is ADHD. I actually have a very similar doormat myself because I also have ADHD. It does not say anything about a hair straightener because I do not have one, but it does say all of the other things on there. ADHD is a very poorly named disorder because it is not a deficit in attention and people aren't always hyperactive. Really what it is a difficulty in what we call executive functioning. So the part of our brain that is responsible for guiding the rest of our brain is our executive functioning. It's what makes decisions. It's what connects every part of our brain to the other parts of our brain. It's what guides our attention and our focus to things. So it's not necessarily that you can't focus on something, it's that you can't decide what you want to focus on. Someone with ADHD might have hyperfocus, where they're focusing on one thing for 3 hours and they can't pull their attention away from it. And that's very similar to not being able to focus on anything at all. It's not a deficit, but it's an inability to decide what you're doing with your brain in that moment. So you can see that coming across as impulsivity, hyperactivity, when people can't use their executive functioning to control their behavior. They can't focus on something for long enough to stay still, so they're all over the place. But you can also see the inattentive side of that. You can see forgetfulness, daydreaming, people being very messy because they can't really stay focused enough or organized enough to be organized. A lot of times you see people who, if a child is just like, they never pay attention when I talk to them. They're always lost in their thoughts. That can be a manifestation of ADHD. And someone can not be hyperactive at all, but have this sort of presentation instead. The other thing you see that's more of a functional component is how you approach tasks. There's a difficulty starting tasks, a difficulty switching tasks, difficulty finishing tasks. That can manifest a lot in school or in chores, in that someone just never really does what they're told to do, but it's not because they're lazy, it's because their brain just can't quite click with doing that thing. This is also very comorbid with depression and anxiety. You can imagine if you can't focus long enough to deal with your problems, or if you can't get that focus to pursue a goal, that can cause anxiety and depression in people. One thing that we know is it's more likely to be diagnosed in boys. That is emphasized because it is actually equally likely to occur in girls or boys, but it's more likely to be diagnosed in boys. There's some gender stereotype going on. We know some people say that it's because boys are more likely to be hyperactive and girls are more likely to be inattentive. That's actually not true, but it does seem like girls are likely to be overlooked if they're hyperactive, and it's really the inattentiveness that is picked up. Said that backwards. The inattentiveness is ignored in girls, it's picked up in boys, but the hyperactiveness is picked up in both. So there is some underdiagnosis, and that's something that we in psychiatry need to be aware of when we're assessing people for this diagnosis. We also know that there's a difference in diagnosis of ADHD across race boundaries. So a lot more likely to be diagnosed in white people, and people of other races tend to be diagnosed with other disorders like conduct disorders or defiant disorders, which sound a lot more nasty or mean. And that's something that we also need to be better with. Yeah. Of course. And we are getting to that at some point too. So thank you for asking that question. Unlike depression and anxiety, which you can have a single episode of and be at risk of recurrence, but it can go into remission, ADHD is really a lifelong diagnosis. So we think about ADHD as being important in school, but you can imagine if your job requires you to be at a desk for 8 hours a day, it can really be impairing to your functioning. If your job requires you to answer a whole bunch of emails and keep that in order, it can really impair your functioning. If you're a stay-at-home parent and you are doing chores all day and you can't organize yourself enough to do chores, that can be very impairing as well. So some of the summaries of the signs we've talked about so far when we think about mental illness in adolescence is changes that are persistent in mood, personality, or behavior that don't have clear explanations, unexplained changes in their functioning in school or other areas of their life, or their enjoyment of school or other areas of their life, changes in sleep, appetite, or self-care, not changing their clothes, not doing their hair, not brushing their teeth, taking showers as much as they should be, and increased avoidance of things or seeking reassurance or attention of other people in a way to manage, for example, the anxiety piece. So the other kind of category of concerns I want to talk about today is self-harm and suicide, which is a very, sensitive topic for a lot of people. 988 is the 3-digit number for the suicide hotline now that you can call or text. It used to be a much longer number, but they managed to shorten it to a very quick number that is easy to remember. So with self-harm and suicide, the important thing to know is it's a symptom, not a diagnosis. It's always going to be associated with some other mental condition or mental issue that someone is dealing with. And there are many potential causes of it. So there are a lot of assumptions that are made about both of these topics. But a lot of different things can lead to these feelings that people have. And the way that I tend to conceptualize these issues is that all behaviors have a function, even if they don't quite make sense. And oftentimes when you think about these behaviors, it's something about emotional escape. So emotional pain, just like physical pain, they have very parallel pathways in our brain. And physical pain is telling us, get away from that situation, get out of there. Emotional pain tells us the same thing. This is a bad situation. This is scary, leave. Now you can imagine if you have emotional pain that just isn't going away because it's a mental illness and not a functional emotional pain, you can't escape that. You can't get away with that. And that causes an urge to escape. So both self-harm and suicide sometimes are a manifestation of some sort of drive to escape that people can't quite realize. A lot of people who engage in self-harm, for example, say that it helps reduce feelings of emotional distress for them. There's also a piece of emotional expression. So a lot of people would say the term, oh, they do it for attention. That's not that's a very stigmatizing thing to say, but it's not entirely untrue sometimes. But the question to ask is, well, why do they feel like this is the only way they can get attention? Why do they feel like this is the only way they can tell people they're in pain? That's a problem, and we need to think about that and think about how to help this person communicate their distress a bit better. And there's no one type, and by that I mean there's no one type of person. I've seen both of these issues happen in all types of people, all ages, all backgrounds, all diagnoses, and there's no one method. We tend to think of self-harm as cutting or something, but people can put their hands under burning water, people can hit their head. There's a lot of things that are done. As far as methods, I do want to say that we know conclusively that firearms are the most effective way of suicide, so to speak. So when we think about means control, which is the most effective way of suicide prevention, that's often the first thing we think about. How can we get dangerous things out of the environment? And the first thing we always think about is there a gun in that home? How can we get that out of there? As far as how we respond to these issues in psychiatry, we're trained very well in how to do what we call a risk assessment, thinking, is this a chronic issue? Is it an acute issue? And is this an issue that causes an acute safety concern that we need to be very concerned about? But the first thing that anyone should think about in these situations is never be afraid to ask. There is a myth that asking will increase the risk someone will act on it. If they weren't thinking about suicide before, asking about it will cause them to think about it. That's not true. We know that asking someone if they're feeling suicidal does not have any increase in risk of them feeling that way or acting on those thoughts. Don't be afraid when asking. And what I mean by that is ask directly and calmly and validate emotions. So oftentimes in psychiatry, what we learn talking with patients is that the way we feel and the way we express the way we feel influences how patients who see doctors as authority figures think about how they should feel. So that's similar when an adult is talking with an adolescent. If the adult feels nervous or scared or uncomfortable, that will influence how the adolescent feels. So the best way is to ask directly and calmly about these issues and not kind of communicate that this is something you're really it's normal to express that you're worried, but don't express kind of a judgment, so to speak. And the important thing to do is validate emotions. And what I mean by that is validate the emotions. I'm not saying validating self-harm or suicide or anything of that sort, but it's important to say, I know that you're feeling in pain. I know that you're feeling sad. I know you're feeling distressed, and providing that support, because we know when we do interviews with people who have attempted suicide, that the most highly cited thing as one of the reasons for it is a lack of support or a perceived lack of support. And prioritize safety. So I have friends who are lawyers, and they're telling me I should limit how much precise information I give on this topic. But the main thing I will say is know how to recognize an emergency. But when you're talking with an adolescent, collaborate on increasing safety is important, not being entirely like, you're saying here, we're doing nothing sort of thing, but asking even, how can we support you? How can we keep you safe? Oftentimes that involves keeping the environment safe. What are some things that are dangerous? How can we limit your access to those things or supervise you when you're doing those things? Providing greater supervision if there is a concern, and recognizing an emergency. So what I will say about that is that's a very nuanced risk assessment that, as I said, psychiatrists are trained to do. But the main takeaway point for the general public is, if you ever feel like something is an emergency, then it's an emergency, and you should seek immediate help for that situation, because the most important thing is keeping people safe, and everything else comes after that. So those were the main categories I was talking about. I know there was some questions about treatment. So when I put therapy up here, this is really a bait and switch, because therapy in medicine means any sort of treatment. That means pharmacotherapy, including medications, as well as psychotherapy, which is what people usually think when they hear the word therapy. So as far as depression, anxiety, and ADHD, I've grouped them like this because the medications we use for these conditions of depression and anxiety are very similar. We use medications called antidepressants, which is an unfortunate name because they also are anti-anxiety medications. They're equally effective for both. As well as needed options. We tend to avoid things like Xanax or Valium or benzos that are addictive, but there are certain non-addictive as needed medications we can have people use, especially if they have kind of more of a panic sort of anxiety picture where there's episodes of heightened anxiety that they need to get through, or if they have things that they know will cause them anxiety, like being on a plane or public speaking. And the thing to know about medication for these conditions is that time is key. So one of the things that I hear the most often is, oh, I tried Prozac, it didn't work. Well, how long did you try the Prozac? 2 weeks. That is not long enough to know if it works. We know that antidepressants take at least 4 to 6 weeks to see maximum benefit, and oftentimes it can take even more than that. So an adequate trial of an antidepressant is at least 2 months at an adequate dose. One of the unfortunate things we see is that people who get their medication from a primary care provider, which is most people because there aren't enough of us to go around, is that they get started on a medication at a starting dose, follow up in 3 months, and in those 3 months, they're still on a starting dose that's actually not a treatment dose, and they haven't been treated for 3 months, but now they think it doesn't work for them. So an adequate dose for the adequate amount of time is important, and if you haven't had that, you haven't had an adequate trial of a medication to know if it works for you. Yes. Yep. So we know that doses cause. So someone had asked the difference between a starting dose and a treatment dose. So we know that medications like antidepressants take a long time to work. The unfortunate thing is that the side effects tend to be a lot more upfront. So we notice side effects within the first couple of days, and they start at lower doses than you would expect someone to receive benefit from. So you start a lower dose to limit side effects before going to a higher dose that you expect someone would benefit from. But you usually start the starting dose for a couple of weeks and then go to the treatment dose. But that requires closer follow-up than a lot of people who are primary care providers and have a lot of other concerns are able to do. And that's one of the barriers to adequate mental health treatment, is knowing that there's just not enough of us to go around. Wait times for an appointment can be 4 to 5 months, which is very unfortunate. For ADHD, medications are stimulants and non-stimulants. So stimulant medications are like Ritalin, Adderall, And there are a variety of non-stimulants. So all of the non-stimulants are considered second line. They are known to be less effective than stimulants. When treating ADHD, we know that medication is by far the most effective way to treat it. There are some behavioral approaches, but really it's the medication that tends to be the most effective for people. When you think about ADHD, it's not just the focus or the attention that you're creating, it's all of the other things we talked about, the dysfunction someone has in their life, the risk for anxiety and depression. A lot of times when I talk with parents, they're worried, well, I don't want to start my child on a stimulant. Isn't that like, cocaine or meth? It's similar to that, isn't it, right? What we know is that because ADHD increases that risk for impulsivity, it increases that risk for hyperactivity, kind of thrill-seeking almost. Treating a kid with a stimulant actually decreases their future risk of substance use in their adult life. So it's an effective medication. It's a well-tolerated medication. There are known side effects, but most kids are able to tolerate them well. And it is something that I advocate very strongly doing for kids who have a very clear diagnosis of ADHD. Now, because ADHD involves impairments in concentration and hyperactivity and other things, sometimes it's overdiagnosed in certain kids. So it really needs a thorough evaluation to be confident that that's what you're treating, because things like depression and anxiety, a stimulant can actually make worse. So you need to know that you're treating what you're treating, but in a real bona fide case of ADHD, a stimulant is what you want to go with. Although there are non-stimulant options available that we do know are effective for people as well. When we think about therapy, there are a couple different options for depression, anxiety, or other conditions. So supportive therapy is what you think of as talk therapy. It's really providing kind of a person that you can trust, that you can talk to, that you can have a weekly check-in with and have a routine connection in your life to work through a lot of your issues. But it's rather unstructured as a type of therapy. CBT, or cognitive behavioral therapy, is a more manualized approach. It's a more skill-based approach. It's let's think through what behaviors or emotions or thoughts are problematic and have a stepwise approach to addressing those things. It tends to be more, quote, evidence-based, but that's largely because it's easier to do research on something that has a very standardized manual. But it is a very effective approach for a lot of conditions for people. With adolescents, family-based therapy is also something that's very effective, especially if there is some sort of dysfunction that is noted to be occurring in the family. There's other children who are, also having some issues, and that might be impacting the relationship in the family. If there's, some difficulty or conflict between parent and child that's not being addressed appropriately, that's contributing, that can be effective. So this is a type of therapy that we use in adolescence that is not really available for other people, because we know that the family environment is often very important in how someone, regulates their own emotions, how someone regulates their own behavior is based on how they model off of their parents. So this is something that we can often use effectively, kind of almost coaching the parents. How do you model this well for your child? In ADHD, there are what we call behavioral strategies. So I often tell people with any medication, this is not going to cure you 100%. This will make it easier for you to address the other issues. Medication is more of a sledgehammer approach in that it does not target all of the nuance that a mental illness has. We don't have any medication that perfectly targets every single pathway that causes depression, but it targets it enough that it reduces that stress to the point that someone's actually able to function enough to then fully recover. And if someone can't function enough to recover, well, then they need a medication to get to that point. With that being said, ADHD, there are behavioral strategies too, using a planner, using a reminder app, putting sticky notes everywhere. People tend to learn these things over time, but sometimes talking with a therapist or some other provider about, well, what works best for you, let's do a trial and error approach is helpful. And then with any of these conditions, but I think ADHD is the one that you think about the most, school-based accommodations are also very helpful. Talking with teachers, talking with administration at a school and thinking, well, how can we support the child get around some of these barriers? And like I was saying, sometimes we think about these two things as entirely separate. You get a medication or you get therapy. Really both is what we know to be by far the most effective for people. Yes. Mhm. It's a very great question. So what we know about ADHD is that it's not, in essence, that hyperactivity or that lack of focus, but it is that lack of executive functioning or that ability to kind of control one's mind and one's focus and what one is doing. I like to think of it as a kind of loose plug that's not entirely plugged in. So the part of our brain that has executive functioning is called the prefrontal cortex, or the part right in the front. And then the connections to that to the rest of the brain aren't as strong in ADHD. So it's almost like that plug is not quite plugged in. A stimulant will sort of put more dopamine and norepinephrine and other neurotransmitters into that area, kind of forcing that plug in. So if you have ADHD, being able to have more of that functioning in that part of your brain helps with the hyperactivity, helps with the focus, and helps those symptoms that way. If you don't have ADHD and you take a stimulant, it will worsen your anxiety and your hyperactivity and your focus, because it will kind of increase your anxiety, so to speak, because some of these medications can also worsen anxiety, which is one reason maybe you would avoid a stimulant in someone with anxiety and ADHD. But we do know I've treated many people with ADHD and anxiety with a stimulant alone, and their anxiety went away because now that part of their brain that wasn't handling things well is handling things well, and they're less anxious because of that. But yep, therapy has a longer wait list sometimes than stimulant. Mhm. So we haven't seen any data for that. We do know that we've had these medications for decades, about as long as we've had the DSM. And we've had a lot of people live their entire lives taking these medications, and it does not seem like there is a overly big concern for that tolerance. Now, that's actually sometimes something that we see in cases of real ADHD or ADHD that's, I want to pass a test in college ADHD, is that people who take a stimulant more as a not real indication tend to have more tolerance, but people with ADHD actually tend not to experience that as much. Sometimes you see someone who's in their 40s who's like, I don't quite feel the same on this as I do on when I was 20, and I need to increase the dose a little bit, but it's not like ever increasing doses. It's more like you slight tweaks throughout a lifetime are enough to manage for most people. Um, so getting towards the end of our talk, some major misconceptions about mental illness. Here's one I hear a lot. There was a black box warning for suicidal ideation in adolescents for antidepressants, and I think it was recently increased to young adults, so up to 25 or something of that sort. We do have a lot of data on this topic. It's one of the most researched topics in mental health for children. There is a signal when you look at very large studies of tens of thousands of kids that there may be an increased risk of thoughts of suicidality with antidepressants. There is no signal for increase in suicidal behavior. So there might be an increase in thoughts, but there is no safety risk with this. We also know that untreated suicide is a much higher risk for suicidal ideation. Untreated depression is a much higher risk with suicidal ideation than the slight signal you might pick up looking at tens of thousands of kids who are started on Prozac. So the biggest recommendation from the American Academy of Child Psychiatry is that if someone needs an antidepressant to treat their depression, give them the antidepressant, because the 0.001% risk that we might see of increased thoughts is nothing on the increased thoughts and behavior you would see from untreated depression. I don't want him to be on drugs. We kind of addressed that issue with the ADHD question already, in that treating mental illness tends to decrease the risk of risky behaviors, including substance use. So medications like antidepressants are not addictive. They are not tolerance inducing. You do not have that same rewarding behavior you'd get from illicit substances. Stimulants, you do see that rewarding behavior from it. It can be abused, but when used properly at the right dose for the right diagnosis, it does reduce the risk of other substance abuse. So these are not medications that are addictive or any sort of way when used responsibly. and antidepressants aren't addictive in any case. She doesn't have any reason to be depressed is another one I hear a lot. Depression, as I said, is dysfunctional. It can be an environmental response, but it's often from nowhere at all. I've seen people at very great places in their lives become depressed, and it's just a thing that their brain does, and there doesn't have to be a reason for it to be very impacting on someone's life. I hear the kids say this one a lot. This is in part true. We do have an approach, which sometimes we do in cognitive behavioral therapy, especially called behavioral activation, or getting out and getting that rewarding behavior to try and build up sort of a habit of doing things that make you feel good that actually then will make you feel good. But that is a very structured approach that you need to do in a stepwise way with someone. You can't just tell someone get better and you'll feel better. You can't tell someone with a broken leg, hey, you just need to walk on that. You need that, you can do physical therapy, which includes walking on your leg, but that's a very structured approach to gradually increasing your ability to do that. People who have depression or other mental illnesses, yes, maybe they need to touch more grass, but they need help doing that. Here's another one that we often see, and we often hear concerns about being entirely honest with psychiatrists because people don't want to be involuntarily committed, or they don't want to have consequences for their job or their work for other people to learn about it. First of all, we have doctor-patient confidentiality. We would not tell your job ever that this is a thing that you're experiencing or your school. And when we see a patient in the clinic, we do a very thorough risk assessment. And most people who tell me they feel suicidal, I am not going to try and lock them up. I have actually never done that for someone in the clinic. Sometimes I see people in the emergency department who are a bit more high risk. But the vast majority of the cases, this will just get you the treatment that you need. And you will only be required to be in the hospital if there is a very high risk that you will hurt yourself very soon. And that is the vast minority of people that we deal with. A lot of people feel very scared by their own suicidal thoughts. And we know in the vast majority of cases, yes, it's something that needs to be addressed quickly, but it's not something that we need to address tonight or you're going to be dead tomorrow. So please be honest with your doctors. We just want to do the best by you. Here's another one I hear, especially with younger children. I've seen 8-year-olds express suicidal thoughts and have suicidal behavior, so I would never consider someone too young to have this sort of experience. We didn't talk about some of these last ones, but I do hear a lot of people say, well, weed isn't addictive, it's safer than alcohol. You are less likely to overdose on weed, but yes, you can have a weed addiction. You can also have impairment in your cognitive functioning. You can crash a car on it. You have a higher likelihood of doing that. And depending on if you have an underlying heart condition, you can certainly have very dangerous reactions to cannabis. A healthy 26-year-old might not, but you never know. And we also know that it can interact with other medications in dangerous ways. Here's one I put out there. I intentionally used the word he. Just like any other diagnosis, anyone can have an eating disorder. I have seen people who are 500 pounds who eat nothing but a salad leaf a day, and they actually have signs of starvation, but their body is just such that their metabolism, they don't lose weight by starving themselves, they're still doing it. No gender, no appearance, no weight or size is not able to have an eating disorder. Yes. Yes, so that is another major reason to avoid cannabis, is that we do know in the developing brain, again, before the age of 26 is when we have that data. When you use cannabis, you have a higher risk of developing psychotic disorders. Now, it's still not entirely clear if people who are in the process of developing a psychotic disorder are more drawn to weed, or if people truly have a higher risk of that. We do know if you have family members who have schizophrenia or bipolar disorder, you're more at risk of developing that condition if you're using weed. If you don't have a family history, it's still unclear, but the advice I tend to give people is until your brain is fully developed, stay away from this stuff because there is a higher risk of that. It's a low risk, but it's a risk that you don't want to play with. So some of the things about being healthy. I talked about support and acceptance, having a community, having friends, family, found family, having some sort of connection that you feel supported by and belonging in is very important. This is something that every adult can do for every child in their life, is make them feel loved and accepted. And this is a way that we can all be very helpful in a very easy way. Regular routines, which include, I put, that actually doesn't make too much sense. It makes sense to me, but what I mean by that is we generally say wake up and fall asleep around the same time every day. Now, a teenager is probably going to be waking up at 6:30 for high school every morning on the weekdays and then at 10 a.m. on the weekends. That's just how their brains work. But we do know that it is the healthiest for your sleep if your wake up time does not vary by more than 90 minutes. Include free time. I know a lot of high achieving high schoolers and college students and medical students and doctors who do not have free time, and that is not healthy for you in the long term. I tell every young person I meet, you can still be a doctor and have free time in high school, and it's very important to have time to do what you enjoy doing. 8 to 10 hours of sleep is what we recommend. We do know that adolescents actually need more sleep than average. They are going to be more towards the 10-hour range of this. And we also know their circadian rhythm is such that they just naturally fall asleep later and wake up later. That's kind of a change that happens as you grow into adolescence. And then we torture that brain by making people wake up early in the morning for high school. But the recommendation that I heard from a sleep doctor, which made a lot of sense to me, is you should not be woken up by your alarm most days of the week. If your alarm is waking you up, that's because you did not finish getting the sleep you need and wake yourself up. So if you're waking up by your alarm every day, you need to fall asleep sooner. We know that electronics like our phones and our laptops and our iPads, they give us a lot of blue light. That blue light is what our brain uses to recognize when it's dark out. So we recommend at least an hour, if not longer, before bed, you need to not be using your phone. A recommendation I give to people, charge your phone outside of your room. Don't leave it on your nightstand. Avoid the temptation. Diverse activities, the combination of relaxing and challenging. You need to be challenged to go further, but you also need to relax, and being healthy and getting that exercise is very important for people. We recommend at least 150 minutes or 2.5 hours a week of physical activity, which I definitely do not get, but I try to. 3 square meals a day. We know if you're trying to lose weight, the best way to do it is to actually eat 3 meals a day. One thing that I hear a lot of people who are at risk of developing an eating disorder probably do is they say, well, I skip breakfast or I skip lunch. That's how I lose weight. That actually is known to not be as effective as eating 3 square meals a day. That is important for routine and important for your nutrition. And then social media is another thing that I know a lot of people are worried about nowadays, especially with some of the governmental warnings that are being put out. The data that we have is that the amount of time you use social media is not associated with worsening mental health. And the real research now is on what type of social media is healthy and what type is harmful. People use social media to connect, to talk to their friends, to, kind of express themselves. Some people write stories that they post online, and all of that's a very healthy activities to be engaged in. There are also unhealthy ways to use social media. There are unhealthy medias to be engaged in, and it's really a conversation about what are you using the social media for and how is it helping your brain versus hurting it, rather than the amount of time you're on Facebook overall. You've taken Psychology 101, you recognize Maslow's hierarchy of needs. I see a lot of people smiling in here. What this is essentially showing is that we need to take care of the basic stuff at the bottom, like food, water, shelter, safety, before we get to the top, which is self-actualization, which I have no idea how the heck to do that. But we know there's a lot of challenges facing our young people nowadays. So this is my soapbox to say, these are things that are really stressing our kids out. We know that we have 15-year-olds saying, will I ever own a house? We have 15-year-olds saying, well, when I'm a grandma, will I still have a healthy environment to live in? When I've talked to teenagers who are worried about seeing me as a psychiatrist because they're worried about being deported, even though they're actually not at risk of being deported, but they just get this message in the news. COVID-19 separated kids from other kids for such a long time. It's still impacting a lot of people today. There was isolation, there was disruption in school. people are still recovering from all of that disruption and political division. Your kids might not entirely understand, depending on their age, what's going on in our communities and our government nowadays, but they know adults are stressed out and they're stressed out. And they do understand more than you think they do. And then social media, again, is it helpful? Is it harmful? The jury's still out, but we do know there are harmful ways it can be used, and we need to be mindful of that. Some things we can do: promote healthy habits, pay attention to your kids, pay attention to yourselves if you're a kid or if you're an adult, whatever your age. Know when you're not feeling good and know how to get help. Don't be afraid to ask about mental health of your friends and family, and to ask for help for your own mental health, and support the kids, care about them. We have some pamphlets with some resources that I have. There are local community clinics. There are some community groups, some LGBT groups, some community spaces. They also have resources, some of the resources on the pamphlet for like food and clothing even. There are some hotlines, some general ones, some culture-specific ones, and some websites where you can get some further learning from some very reliable sources that are not TikTok. Yes. They are not. Oh, yes. There was a question about if antidepressants are not addictive. So we know that they do not have a rewarding response. They do not give people a high like a lot of addictive medications do. There is not a risk of developing tolerance from them, and people do not seek them out to abuse them. We do know in some cases it's hard to get off of them because of withdrawal symptoms, but in the most part, they can be tapered off very successfully. But they do sometimes are hard to get off if you just want to stop them cold turkey. So sometimes it can take a month or so to get off of medications because of withdrawal symptoms, but the other aspects of tolerance, abuse, or any of that, you do not see with antidepressants. Any other questions? Or was I just that thorough? If you ask the DSM, there are some age cutoffs, but I think a lot of these issues can affect people regardless of their age. I've never seen someone who was 2 years old, for example, but I've known a lot of 5-year-olds who have had some pretty serious trouble because of things they've experienced earlier in life or because of the way their brain was wired. So I wouldn't say any age is too young. Now, if they can't talk yet, maybe that's too young, but I wouldn't say no. Mm. Mm. So I do have some limited time during this talk, and a lot of these conditions, and I will say my own interest is psychosis and bipolar disorder as a personal interest, but I wanted to cover the most common kind of conditions and cover the most broadest categories to give the best useful information I could, and had to make some choices about what I could cover and what I couldn't. You had a question. So all of these diagnoses are hereditary to an extent. We know every mental illness is a combination of environment and genetics. ADHD tends to be one of the more hereditary ones. So if your parents have it, you are fairly likely to have it yourself. It is also one of the diagnoses that there seems to be more genetic impact than environmental impact. So a lot of these conditions, depression, anxiety, you can be predisposed to them, but something in your environment hits you off. ADHD is more purely genetic for some reasons we aren't entirely sure of yet. Mm. Mm. Yeah, so again, I think it's more so how you use it. Do you use social media to connect with friends, to connect with family? Do you use social media to learn? Are you looking at educational pages that you're following, for example? Or are you looking at things that can impact your self-esteem? Are you looking at, things that can impact your self-image? Are you going through things so quickly that it's really just giving you a dopamine hit and not really doing anything else for you? Is it eating up time that you'd better spend doing something else? Which is the piece, the caveat to the time piece, right? Are you spending 3 hours on social media when you're not spending time in person with friends who you could be spending time with? That could be a problem. But if you don't have the ability to spend in-person time with friends, are you on social media communicating with them? That's a healthy way of using it, for example. So it's a very nuanced question, but a lot of what we know about social media is it's not just using it that's harmful. It's how you're using it and how it's impacting your time off of social media. That should be part of the conversation. So rarely any research yet. There is some question of, are there reduced attention spans because we spend a lot of time online? There might be some signal of that. But if that's social media versus is that TV versus is that something else entirely that isn't internet related, we're not entirely sure. We do not see any attentional problems as far as using social media goes for adolescents today. But that's still an open area of research. Is this having some longer term impact of using chronic social media? As far as we know, we don't have any clear data that it is, but it is reasonable to think, depending on the type of social media, again, are you using something that you really think about and process cognitively, or are you using something that's just filling your brain for 3 hours and you're not really thinking about it? Does that latter thing have a detrimental impact? Possibly. But the research is still out there.